Okay, now I want to talk about a really serious issue here, glioblastoma multiforme, and this is a really bad one, poor prognosis, and unfortunately Senator John McCain is now struggling with this kind of a tumor. You know, it's a nasty tumor. Multiple different kinds of cells, no effective therapy. So you get a whole bunch of different kinds of cells, consequently the name multiforme. Highly invasive. All right, so when you look at a brain tumor, here's a poor soul that sacrificed their brain for the study. And you can see this nasty necrotic area, large cyst. But if you look at the midline of the brain, you can see it shifted to the left. This is called midline shift. Okay, so these tumors grow and they cause intracranial pressure, and people die from intracranial pressure, most of the people who have these kinds of tumors. And the problem is you can't surgically resect them because the tumor cells have already spread out into the normal appearing size. And the tumor cells, one of the mechanisms they use is they go across the surface of blood vessels in the Virchow-Robin space. So they use these blood vessels as kind of a railroad system to get through the brain. So it's very, very hard to any kind of surgical resection. And you can see them, the dark blue cells around the blood vessels are you can see on histology. Histology will tell you. So this is how they spread through the brain and make it very difficult to get resolution. And we all know that mitochondria are abnormal in brain cancer. And this shows you a picture of an electron micrograph. The only way you can see mitochondria clearly is EM, electron microscopy. And the stripes in the mitochondria contain the proteins and the lipids of the electron transport chain that allow us to get energy through oxidative phosphorylation. So you can see the nice stripes on the normal mitochondria there. And the GBM mitochondria, mitochondrial glioblastoma multiforme, is called crystallysis. The very structure of the organelle needed for oxidative phosphorylation is missing. Anybody can see there's an emptiness in that mitochondria. The stripes are missing. The stripes are missing, therefore the oxidative phosphorylation is missing. Therefore the cell must ferment in order to survive. Everybody see that? Okay, there's a lot of papers in the literature showing that, yet many members of my field say mitochondria are normal. They obviously don't look at this, or they don't want to see about it. They ferment. They have to ferment. They don't have the structure. Structure dictates function. Without the structure, you can't get the function. The function is abnormal because the structure is abnormal. And my colleague, Gabriel Arizmendi-Murillo, has published many beautiful papers on this. So if you can't get energy from oxidative phosphorylation, where do you get the energy to drive the beast? Where is that energy coming from? It's coming from glucose and glutamine, the two prime fuels that are going to drive the beast, but they can't eat anything else. It's not there in sufficient quantity. We did the logistics on this. These two fuels are abundant in the microenvironment. So they come in, right? They two together, they're synergistic. Glucose, glutamine, they come in, they fire the glycolytic pathway, the pentose pathway, the glutaminolysis pathway, driving energy from substrate level phosphorylation, making all of the stuff, the DNA, RNA, proliferation. These cells grow like crazy. So what do we do in the clinic? Okay, so some poor soul comes in, diagnosed with a glioblastoma, devastating. You know, people don't know what they're, almost like the head. You're just devastated. The patient's devastated. The family is devastated. You know, it's my God, what's going on here? Well, we got to get you in and cut that tumor out right away. Sometimes you have to do that. This is a herniation problem, but many times you don't. You have a watchful waiting period. No, we get them in as quickly as possible. Okay, we're going to debulk the tumor. Surgeon gets a hold, out comes the tumor. Patient sitting there, wakes up, oh, wow, hey, how do you feel? I feel pretty good. Okay, now as soon as you recover, we're going to start giving you radiation therapy. So in the brain, neurons and glia have a very close connection with each other, intimate relationship, right? It's called the glutamine-glutamate cycle. It keeps our neurotransmitters in balance and everything is under control. You break that glutamine-glutamine cycle, glutamate, which is an excitatory neurotransmitter, comes out, excites neurons, they die, you get necrotic death. Astrocytes take up the glutamate, turn it into glutamine. Now, those tumor cells that have not been debulked will now sucking down the glutamine created by not only the wound from the surgeon, but also the radiation that's blowing the hell out of the microenvironment in this tumor, creating a vast amount of glutamine, which I just said is one of the powerful fuels driving the beast, right? Now, when you take somebody and surgically resect and debulk them and then start radiating their brain, you start to get head swelling, brain swelling, from the radiation causing the heat, the edema. To reduce the edema, we give them high-dose steroids. High-dose steroids create hyperglycemia, right? Glucose and glutamine are now created by the very procedures that are used to treat the patient. Now, to make matters worse, 90% of the brain tumor cells are infected with human cytomegalovirus, which is a supercharger for allowing the tumor cells to use glucose and glutamine. So I published this paper in Lancet Oncology saying that the standard of care contributes to the growth and the recurrence of the tumor, based on hard biochemical evidence. What do you think the response is? You don't want to hear about it. Now, let's test the hypothesis about what I just said. Okay, look at the results from treating patients with brain tumors with the standard of care. So we have two lines here. The red line are those individuals that got radiation alone, and the blue line are those individuals get radiation coupled with the toxic alkylating agent called temozolomide. And the fact that temozolomide could contribute a little bit to survival was the single greatest advance in glioblastoma management in the last 50 years. Can you believe this? I was at when they said this. Now look at the red line, the guys that got the radiation alone. How many survivors came out of this study? What's that number down at the end there? 0. This has been reproduced. You want to know about replicating data? This has been reproduced in every country in the world over and over again. Nothing is more certain than irradiating people and having them all dead. Now we throw in temozolomide, but hey, listen, temozolomide is doing something. Wow, making you get a few extra survivors from this. So I said to myself and my students, what is temozolomide? So we looked and we found out the adverse effects of temozolomide are diarrhea, vomiting, nausea, and fatigue. Wow, these are all indirect forms of calorie restriction. So we published and we said, we think that blip is due to indirect calorie restriction. How do you think? Do you think anybody ran out to test that hypothesis? No. And temozolomide also increases driver mutations. What the hell does that mean? Shouldn't temozolomide make the tumors grow faster if they increase driver mutations? We don't see that. Now let's put a face on this. Okay, so this is Brittany Maynard. She was a young California girl, Northern California, diagnosed with brain cancer in January 2014. The tumor was a small, low-grade tumor. And within 1 month after taking out the low-grade tumor, it morphed into a glioblastoma multiforme. She was then treated with standard of care, heavy doses of steroids. And you can see her face on the right there. It looks totally different than when she just got married over here on the left. That's called moon face from overdosing steroids, all right? So she says, I'm out of here. She's going to go to Oregon, next town up, next state up, and die with dignity with her family. She's going to throw the towel in. And she put an article out, was in People magazine, about her decision to die. And the People magazine article was all about the morality of death with dignity, nothing about the miserable failure of the standard of care that put her in that position in the first place. Now, what does it say when your patients kill themselves rather than continue with your therapy? Not good. Now, let's look at another face. This is Pablo Kelly. Same age as Brittany, about 28. He's diagnosed with glioblastoma in August 2014. He emails me and says, can you help me? I don't want surgery, I don't want radiation, I don't want chemo. So I give him the kit that I send to most of the cancer patients who contact me. And I said, hey, you might as well try it, Pablo, because I'm definitely not doing it. He's from Devon, England. He says, okay. So I give him the kit. I hadn't heard from him. I didn't, maybe a year and a half go by. All of a sudden, I get a letter from Pablo. I said, oh, geez, Pablo. Pablo is still alive. So he went on. He had this big YouTube video telling everybody how he was going to do keto and all this stuff. But anyway, he says his formerly inoperable tumor now has become operable. So he asked, I said, well, if you can shrink it down, get it out, Pablo. So he goes out and gets, it was earlier this year, gets the tumor out. He has a few seizures, but his quality of life is pretty good. His wife just had a baby. He's still alive. He's doing well, right? He has a quality of life. He's alive. So what we did, knowing about all these situations, we built the glucose ketone index calculator, which helps patients and others get into therapeutic ketosis. So if you want to stop the growth of the tumor, the first step you got to do is get into therapeutic ketosis. And it's the ratio of glucose millimolar, ketone millimolar with one of these precision extra keto mojo things. We're testing all these things against chemistry. And it helps patients stop the growth of the tumor. So it makes it easier. Rather than trying to measure the two fuels together, you get a single value. We also built some of the greatest models, the most replicatable models to human glioblastoma, spontaneous brain tumors in the mouse, so you know that they're coming from the host. And you can see this mouse, M3 is a glioblastoma, VM-M3. And on the left here, you can see the tumor. It invades right through the brain using the same mechanisms as you see in human. On the right is the same tumor in mice treated with calorie restriction and ketogenic diets. Hard, we pounded these things. Now, we stopped invasion. You can see there's much less invasive behavior, but we couldn't kill the cells. They're growing. I threw everything at these things. We were fasting these mice. We were bringing the sugars down, ketones up, and the damn tumor cells are still alive. And the humans get much worse. I tell you, I don't understand how the human brain can be. They're so much more receptive to this therapy than the mouse brain is. People say you cure mice all the time. You don't cure mice all the time. You get the mouse that has the same tumor as human, you get the same problem. So I said they must be using glutamine. So we tested the glutamine hypothesis by using 6-diazo-5-oxo-L-norleucine, which is DON. It's been used, it's an old drug. It was used years ago. It worked out for some cancers, not other cancers. You know, it was just one of those things. Some were a little too toxic, some not toxic. Anyway, what it does is it stops glutamine metabolism. All right, I can go through the details. So we decided to test mice with DON. And we decided to put the tumors into the brain and then give them a fast, let them go for 3 days until the tumors are raging, then put them on a fast, and then switch them back either to a high carbohydrate diet or a ketogenic diet restricted, with or without DON. And on the top, then we pulse DON 6, 8, 10, 12. Every other day, give them a little DON, give them a little DON while they're on these diets. We stopped experiments at day 15 because the control guys, they're dying. They're starting to get morbid because the tumors are growing so fast from all the carbohydrates and everything. So we then compare and contrast the brain tissues and the biochemistry of the tumors at 15 days. And we genetically engineered these cells to be bioluminescent so we can see how active the tumor is by putting them into a bioluminescence Xenogen machine. And so we take the brains out of the mice and we put them in these petri dishes and put some luciferin in there, and the light tells us how many living tumor cells there are in the brains of these mice that are treated under these different conditions. And the guys on the top, you see a lot of bright light, reds and yellows and all this. And they're the ones that didn't get anything but the high-carb diet. They're raging. And we have a lot of different studies to show this. The ketogenic diet restricted, you can still see there's a lot of living tumor cells in the brains of these mice. We did not cure these mice with ketogenic diets. They don't invade as much, and I'll show you evidence for that. But when you put the DON, the glutamine inhibitor, together with the diet, we got no light. All right? There was no light. We did this over and over again. And here's another series of individual mice. You know, 1 through 6 guys that got the diet only, and then the other guys, 1 through 8, got the diet with the DON. And that background, that's all background except for one mouse there who had a little breakthrough light. But by and large, we really eliminated the light and the living cells in these tumors by putting the diet together with the DON. The DON by itself is okay, but it doesn't get rid of as much light as putting the DON with the diet. The two together work best. And of course, the gold standard for determining cancer is histology. That's what they do. They take needle biopsies. Oh, you look at the cells, you got cancer. Right? So you have to do histology to determine whether or not what's going on inside the tissue. And when we do that, we have the standard diet, the ketogenic diet restricted, and the diet restricted with the DON. Low power, high power is what you're seeing. And if you look at the standard diet, you go, oh, these cells are piled on top of it. They can't grow any faster than they're growing. The mitotic figures, the cells are densely packed, and that's what you get when you have a high carbohydrate diet. The ketogenic diet, the one in the middle, you can see the white part of the brain there. That's the normal part. And it's blocking the invasion from the dark blue into the white. You can see how much the invasion is over here in the high-carb diet. The cells are spaced further apart. So what it's telling us is the diet is preventing invasion and it's stopping the rate of growth, but they're still growing. On the far right, you got the DON and what we see, that is all dead cells. All right? Blasted, slaughtered these cells. They're all broken, mitotic arrest, necrotic. They're all dead. This supports the fact that we didn't have any light. That's the tumor cells are dead. So based on this, we developed the press pulse therapeutic strategy for humans based on our preclinical studies in mice. And I worked together with Dom D'Agostino, Joe Maroon, the neurosurgeon, George Yu is an oncologist. And we put this together, and I don't have time to tell you where the origin of press pulse comes, but basically, We use press therapies, which can include the ketogenic diet, restricted ketone supplementation, and stress management. You know, you can't believe that when you have cancer, people get stressed out. You have this impending doom. I'm going to die. What does that do? It raises your blood sugar. Cortisol goes up. You've got to have stress management. So we use exercise. We use music therapy. We use yoga therapy. Whatever works to lower the stress of the individual. We use the diet as a press. The diet is controlling the availability of sugar and raising ketones that the tumor cells can't use. Once we get the patient into therapeutic ketosis and lowered stress, we then apply pulses. And we use drugs like 2-deoxyglucose, insulin potentiation therapy. We then hit them with glutamine inhibitors like EGCG, the green tea extract, chloroquine, the anti-inflammatory, and we're working, and we would like to get Don, of course, and others. And then we put them in hyperbaric oxygen chambers. Hyperbaric oxygen will kill tumor cells just like radiation does without toxicity once you remove the glucose and glutamine, get the patient into therapeutic ketosis. So we can replace the entire standard of care with a logical therapeutic process that's non-toxic. And we gradually move the patient from the disease state to the so-called managed state, and eventually, hopefully, to a long-term management and possible resolution using press-pulse metabolic therapy. Now, how does it work? Okay, so here's a paper that we just published on a patient with glioblastoma from Egypt. We can't do this in the United States. You can't do this in England. All right? You can't do it in a lot of places. So we had to go to Egypt, where they read our books, they read our stuff, and they said, okay, we're going to try this. They came to me and told me how they're doing this, and they said, can you help us write it all up? And you know, a lot of physicians can't write papers. I do this for a living, right? So I said, we'll get the data, we'll put it all together, just like we do the mice, and we'll set up a protocol. So management of glioblastoma in a patient with ketogenic metabolic therapy with modified standard of care. That's what we can't do so far in this country. IRBs will not allow us to modify the standards of care. So we took this guy, he came in, his whole left side, he's dragging. You know, he was a metabolic mess. He had pre-diabetes, he had low vitamin D, had all kinds of other issues besides he had a glioblastoma. So the first thing Dr. Elsaka did, we gave him a 3-day water-only fast, and then transitioned the guy to a 900 kilocalorie a day for 21 days with the ketogenic diet. So he's out over 3 weeks before we touched him. Then he did an awake craniotomy. We debulked the tumor. The tumor looks different now. The tumor has a different morphology based on the treatment of the diet up front. You're shrinking down those cells. Then for another 3 months, we gave him chloroquine, we gave him EGCG, we gave him hyperbaric oxygen. Then we were forced into doing standard of care because they have to do it. So, and while he's getting the standard of care, which is radiation and chemo, he's also on hyperbaric oxygen and the diet as well. And then for another 3 months, you can see after that. And now at 24 months, the guy is doing fine, right? Now he's a corn farmer. He's back out working in the fields. So now he's out 30 months and he's still doing. I just got talked to Elsaka the other day. I said, how's the guy doing, the corn farmer? He's doing fine. So he had a little radiation edema, which pisses us all off, something fierce. You don't want to radiate the human brain under any conditions. You know, I don't understand that. It kills me. You know, I'm looking at these poor people and I'm saying, what are you doing? Well, we have to kill the tumor cells. Just take away the glucose and glutamine, you get the same effect. So here's, you can see that. Look at this. Bring his GKI down, glucose ketone index, got it down really nice. Guy's in therapeutic ketosis. And on the bottom, look at this. Okay, you see the red line on the bottom? See his big tumor there? Okay, watch as the treatment continues. At the very end, you see the red line is now straight. All right? We corrected the midline shift, and the guy's doing fine. And it's just not brain cancer. This is a patient who had triple-negative breast cancer from our colleagues in Turkey, in the Istanbul clinic, and they're treating all kinds of lung cancer, pancreatic, all stage 4 cancers. This stage 4 woman comes in with triple-negative breast cancer. Number 1 is in the breast, 2 is in the liver, 3 is in soft muscle tissue. Again, ketogenic diets, hypothermia, hyperbaric oxygen, the lowest dose of chemo possible to remain compliant with the law. I said to Slocum, I said, what happens if we get rid of the chemo? Patient would do better. But you got to do it because you're going to lose your license if you don't. Can you believe this? So anyway, This patient is doing well. We published it in Curis Biomedical Open Access. And somebody, oh, how's that patient doing? How's that patient? Well, Slocum says the patient is still doing well, never lost hair, always had a high quality of life, never got sick. And we're seeing this over and over again. Not everybody. I don't want to make it look like, hey, everybody's doing well. You know, there's a few people who don't make it. They've been beat up so bad by the traditional standards of care, their bodies can't rally. They're so demolished in their ability to heal themselves by the traditional standards of care, they can't rally. So we have this thing, GBM and other stage 4 cancers. I don't consider them as terminal cancers. I don't think they should be considered terminal cancers. Okay? Because we're mistreating the patients. We're putting them into risk of death by the very treatments that we're using to try to save them. Makes no sense. You poison and irradiate people to make them healthy? Give me a break. You got Brittany Maynard, standard of care. And then you get Pablo, rejects standard of care. Oh, they're only one person. No, there's not one. There's Allison Gannett. There's Andrew Scarborough. There's a whole bunch out there. We just haven't published them yet. So conclusions, cancer is a type of mitochondrial metabolic. It's not a genetic disease. Okay? This misunderstanding is the greatest tragedy in the history of medicine, leading to the unnecessary suffering and death of tens of millions of people by a fundamental misunderstanding of what the nature of the disease is. These cells rely on substrate-level phosphorylation. It's the hallmark of what these cells do. They're dependent on glucose and glutamine as the prime fuels for GBM and all these other cancers. They need that fermentable fuel. Who's targeting the fermentable fuels? Nobody. The press pulse metabolic therapy is non-toxic, cost-effective for the management and possible resolution of all types of cancers. It's a singular disease. All these tumor cells are all fermenters. It doesn't make any difference. It's my opinion, and I could be, I don't know if I'll live to see it, that this strategy will eventually make all other strategies obsolete. It's just a matter of time. So I want to thank my collaborators and colleagues from the United States, from Turkey, from Germany, from Venezuela, from Hungary, Greece, France, Egypt, India, and China. The Chinese want to now start dovetailing this into their traditional Chinese medicine. And I'd especially like to thank the funding that we get, which is very hard, believe me. You get massive amounts of money to study cancer. You get very little if you want to try to resolve the disease. Single Cure, Single Cause Foundation, CrossFit, thank you very much. Dr. Joe Maroon, team surgeon for the Pittsburgh Steelers, distinguished neurosurgeon at the University of Pittsburgh. George Yu, oncologist. Ellen Davis, Boston College, and in the past, the NIH. Thank you for your attention.